We move on to the next speaker, and it is clear that if you want to eliminate any disease, you must be able to diagnose it and diagnose it easily. And Professor Sarman Singh, who has contributed immensely to that initiative, would now address us and take us through the journey of diagnosis. As Dr. Mahapatra mentioned, that there used to be times when they would do bone marrow or splenic puncture, and now it's much easier. Dr. Sarman Singh is a very distinguished microbiologist and administrator. He was also the director of AIMS Bhopal, and as you notice here, there are many accolades to his name. I think I will not stand between him and you. Dr. Sarman Singh, please go ahead.
The
Thank
floor
is yours.
Thank you very much. And Dr. Salu, I will request that, you have to be with us. So in sync with, so whenever there is a, even sometimes the speaker forgets, you can change the slide when you know that, I have reached to the end. So next, please. All right. So I think the introduction part, Dr. Rattan and Dr. Mahapatra, they have very nicely given. And probably Dr. Mirda also mentioned that we have three main forms of leishmaniasis: visceral, cutaneous, and mucocutaneous. But obviously, today's topic is visceral leishmaniasis. So I will not delve upon the other forms because they are mucocutaneous. Very few cases are reported from India. Cutaneous leishmaniasis is mainly in the Rajasthan part and Gujarat part. But the visceral leishmaniasis is really important because of it is a high fatality. The number still remains about 1 million new cases annually. We do have. Next, please. I will go a little quicker because on the request of Dr. Ashok Rattan sir, earlier I sent very big slide deck. But it was very difficult to cut it down. But still, little bit slides are more. But I will try to there is a lot of to say, but obviously in 15 minutes, but I will take little, leverage. So still the major thing is why visceral leishmaniasis is important. And this theme has been because as compared to mucocutaneous and cutaneous leishmaniasis, because of the high fatality, Dr. Mirda and Dr. Mahapatra also said, everybody knows about that. So still the huge number of new cases are happening. And we do have, Dr. Mirda, thank you very much for citing our paper. In that paper also, we have said that once there is immune compromisation, particularly in HIV cases, there is 100 times more risk of developing, leishmaniasis, and that too severe form. This is also known that HIV patients, HIV positive full-blown AIDS cases, they can also have the visualization of the non-visualizing species. That is also very important, not mentioned here, but that is very, very important. Now, one thing I would like to emphasize here, that those who have been teaching leishmaniasis, including my old slides, we were having India, Nepal, Bangladesh prominently mentioned here. But now these slides, this is very current data. Here, the Ethiopia, Kenya, Somalia, and both the Sudans, they are prominent. India is still there, but Bangladesh, I will show you in the picture, Bangladesh has already eliminated the Kala-Azar in 2023. Next, please. So 2023 elimination certification means they declared in 2021. The WHO takes about 2 years to observe and finally say. Similarly, India has claimed that they have also eliminated in 2023. And this year, we were expecting Dr. J.P. Narayan will be, because I couldn't find, still the WHO is observing that India has not yet been declared certified. Government of India has declared it is that, Kala-Azar is eliminated from India. And here I must say that, to achieve the Bangladesh and Nepal also is on the verge of, elimination, to claim elimination. So all these three countries, because at that time, 1992, 1991, my, interest developed in leishmaniasis. And Dr. J.P. Willie, Dr. Ashok Rattan knows, those who are in the AIMS, they know that, he treated me as a part of the unit 1 of the medicine. So I was actively involved in that. So that time the number has increased, and during that period, I also had a fellowship in USA, and after returning from there, my work was obviously on the all aspects, but particularly the diagnosis. And I must say here that in 2003, we organized an international symposium at AIMS Delhi, and that was highly successful. Dr. C.P. Thakur was minister at that time, and he personally came and he blessed us. And in that symposium, it was made a point that the government of India should take lead. And in 2003 and 2004, under the leadership of Dr. C.P. Thakur, the India government decided that we will try to eliminate leishmaniasis by 2005. Dr. J.P. Narayan was there because we have interacted at that time, but unfortunately, we took many, many more years. I don't want to go into that detail, but definitely now we are moving, but slowly and steadily. And hopefully any day or any month, WHO can declare that, India is, has eliminated officially leishmania. Next, please. So this is the typically how the typical manifestations in visceral leishmaniasis. As I already mentioned, that about 50% of the affected people are children. Here you can say the spleen and liver enlargement is the typical of that. But in HIV positive patient, this was the first report published from India, mucosal leishmaniasis. So this was a patient from Uttarakhand, and this was, of course, with the permission of the patient, written permission submitted to Lancet. So this is here, you can see the all mucosa, they were involved. So in HIV positive patients, the manifestation can be totally different. So this is the first case reported from India of the mucosal leishmaniasis. Next, please. Now, the diagnosis, I will not go into detail because, of course, the clinical presentation is, of course, very important, but it can be confusing. Depends on the doctor has to take into account the area of residence and exposure. And then, obviously, there are several surrogate markers which are not specific. And then, of course, immunological footprints one has to look into. And then confirmatory diagnosis, which I will dwell upon. Next, please. So the surrogate markers, as I said, you will find, if there is nothing else, then obviously you can have the hemoglobin will be, anemia will be there. Protein, particularly AG ratio will be down, WBC will be less, decreased, and ESR will be raised. And of course, the liver enzymes, they will also be increased. Cytokine, particularly the TNF alpha will also, you will find increased. Next, please. And then, of course, come the other test, which probably before recombinant DNA technology, which I will come to that. Before that, we used to do in our, student life, and when I was early career of my, as a faculty at AIMS, we used to do aldehyde test and Chopra antimony test, which are typically non-specific, but basically they denote only high globulin level. So high globulinemia is there, then obviously there is a coagulation of the albumin, and then you see with the addition of the aldehyde or the aldehyde, stribamin, you can have the gel formation of the plasma. But obviously these are very non-specific, highly sensitive, but very non-specific, because hyperglobulinemia can be in many other conditions, including multiple myeloma and all these things. These days, of course, they are hardly being used. Next, please. And then there were obviously other immunological tests, which are very, rarely being done. Complement fixation was also used in some days, which was having less specificity. There were people, there were reporting immunodiffusion, CCIP, IHA. We have also done when Dr., I was working at AIMS with Dr. Samantre. So IHA, indirect hemoagglutinin test, was also done. IF is still done in most of the African countries to confirm. And then direct agglutination tests, they are also tests which are many countries still doing. India was also doing, and there were a lot of publications from India also. They are highly sensitive, but comparatively, as compared to ELISA, they are less specific. The ELISA's double star means there are many, it will depend. Per se, ELISA can have very, wide range of sensitivity and specificity, but it will depend on the what antigen you are using and what conjugate you are using. And then, of course, we deal with the molecular methods. Next, please. So here, then confirmatory test, or what we call parasitological confirmatory test. Obviously, that Dr. Mahapatra also said that splenic aspirate, which is obviously less sensitive but highly specific, and then bone marrow. Typically, they are the conventional test which we used to do. Liver aspirate also, and lymph node, and then Buffy-coat. Buffy-coat we can use, but that was highly known as sensitive. Sorry. Next, please. And then this was typically how you look into typically the free or inside the cells. You will see that how to puncture the iliac crest, and then I also had opportunity to do that. And then splenic aspirate. Splenic aspirate is highly sensitive as compared to bone marrow, but it is very risky. One cannot do splenic aspirate in primary health center. You have to have facilities for the admission in case there is a sheath rupture of the spleen. So these were the tests, and obviously those days we also reported. It is documented that we in morphologically, when you see the MST goats, what observation, because I was those days during my senior residency and early career as a faculty member in 90s, I was seeing many 40, 50 samples each day. And what I observed, which I noticed and published also, that those patients who were SAG resistant, they were having thick and spindle shape, it was thick and, stout ends of the MST goats. And those were sensitive. They were having more spindle and longer, dimensions. So that was an observation. And probably then I found out that somebody from, Kenya also that reproduced that kind of, information. But then next slide, please. And then came obviously the culture, and culture was also the confirmatory test. And one could do, we were using the triple N medium or the liquid Sneeder's medium, or obviously you can use animals also. So they were the confirmatory test, but again, they were time consuming, and the high rate in triple N, there is a high rate of contamination. So that was there. And personally, I did many, but this is really so fascinating test. But these days, again, very rarely is being used, and otherwise you want to culture the parasite, but not for routine diagnosis. Next, please. So obviously then the era of recombinant DNA technology came. Everybody knows that late 80s, the molecular technology came, and recombinant DNA technology came into existence in early 1990s. And the first paper, this was the Byrne, who was the student of the S.G. Reed, who was the first guy. He was from, I had met Dr. Steve Reed when I was in USA. So 1993, he was doing PhD with S.G. Reed, and he did the recombinant DNA technology. He used technology, and he expressed the cloned and expressed proteins from Leishmania chagassi. And this was published in JMB. And then we also, because Dr. S.G. Reed was a friend of Dr. K.P. Chen, who was my mentor when I was on fellowship. So we also, for the first time, I was having serum samples I took with me to USA. So these serum were tested, and we found fantastic results with the RK39. And of course, after that, when I came back, then Dr. P.N. Tandon was the chairman of the DBT. And then I met him, and then he said, why don't you do something? So I, did it. And what I did, the reason was justification when I was asked that if I want to do my own antigen, the reasons were asked, and the reasons were many. But because the Leishmania chagassi is different in many ways, one is the vector is different, and chagassi, very important thing is that it doesn't, the infected patient will not develop PKDL. So that was another thing. And then when we did the de novo, primer analysis, we found that there were so many genetic differences also, which I am not going into detail. And my student Siva Kumar, he did on this. So all these things are there published. Next, please. So we tried to see this RK39 also a little bit, this slide is important that, most of the patients who are infected, they do not develop visceral leishmaniasis. This is also important slide. That's why I put it here, because about 2/3 of the patients, they will recover on their own. So antibody surrogate markers or the footprint will remain, but the patient will never develop Kala jar. And this was so what we call self-healing. And next, please. And then, of course, as I said, that we tried to develop our own antigen, recombinant DNA, antigen. And for the reason, as I already mentioned, because why we wanted to do, because the Chagas is different and Leishmania pneumoniae is different in many ways, genetically and phenotypically also, and clinically also, as I said. So one, everybody knows that, DD8 is the standard strain, and this KE16 is very important thing, that KE16 is Kala jar camp. I used to go for the Kala jar camps in Bihar. So K stands for the Kala jar camp. E is my A, B, C, D, E. So this was my 5th camp in Bihar, and 16 is the patient's number. So this is a registered number. So KE16, I gave this antigen name as KE16. Next, please. So this recombinant DNA technology was done, and we evaluated the sensitivity of both the DD8, which is a standard strain, and the KE16 strain. And here you can see the upper panel is DD8 and lower panel is KE16. So KE16 up to 25 nanogram sensitivity was there, even though DD8 was also having, but the faint, you can see dot plot, and it was preferred that, we should go beyond the expression thing to the KE16. We also evaluated these antigens on the ELISA. Next, please. Next slide. So here here you can see that, our antigen was highly sensitive. So here you can see that all our controls we included from the various, non-endemic part of Delhi, and then toxoplasma patients, malaria patients, and other, controls, disease controls, as well as healthy controls we included. And we found that our antigen was highly sensitive, as good, rather better than the RK39. So using this recombinant novel protein, we developed latex agglutination test, flow through ICT, and then later flow ICT. And later flow was obviously on the recommendation of the Government of India. Next, please. So the latex agglutination was found to be highly sensitive, but obviously specificity was a concern. And then, of course, we preferred to go for the ICT. And in ICT, we did, as I already mentioned, that we did flow through first. And then the kit was launched. And then Government of India, when it was taken into the program, Kala jar elimination program, then they said that you should make the, lateral flow. So we did, because it is more stable, and sensitivity was, of course, little bit compromised, 1%. Flow through is more sensitive because it requires more, plasma or the blood. So anyways, RK16 was found to be highly sensitive and specific. And I am happy to say that Government of India, took it in the program, and it made significant contribution. Next, please. So these are the figures. This was patented globally using the PCT mode, then America, USA, Europe, and China. Next, please. So this is the lateral flow kit, which was commercialized by the Span Diagnostic. At that time, Span Diagnostic, everybody knows. So 2 dots, one for control, one for patients. And next, please. Then, as I mentioned, that, we went for the lateral flow. Lateral flow. And then this was used for the Kala jar elimination program. Next, please. And then, of course, this was encouragement. Next, please. So then the kit was also compared by WHO and various other agencies. And then this was the sensitivity, specificity. We can see that the KE16 and RK39 both were having 100% sensitivity. Specificity, in fact, KE16 was better, more specific than as compared to RK13. So the Indian or Asian leishmaniasis, both these antigens, they did wonderfully well. But both these antigens, they are not doing, still they are not doing, RK39 is not doing that good in the Mediterranean and African countries. There are many people, they have developed several recombinant after these two antigens, they were commercialized, RK39 and K16. Then many people, they came forward, and then, KL08, then H2A, H28, RGBP, and then, there is a huge list of the antigens they were prepared, but none of the antigen went for the commercialization except these two. Next, please. This is a recent review of the 2025. So how this is a very congested slide, but I will give you the summary and just to show you that how I don't know whether you can see my indicator or not. So almost all these publications, they indicate that the RK39 was having very high sensitivity, and it is being globally, except the African and Mediterranean countries. Next, please. So then also there are antigen detection methods, what is known as CAHO, which again, it is a latex agglutination test, but it is having very low sensitivity, but it is good in HIV VL cases. Next, please. Then, of course, we do have, because time is for the molecular test. Even though the rapid test is doing wonderfully well, but sometimes you have to see the genetic regions or genetic some modulation of the parasite, or you have to do some molecular typing or sequencing. You have to do a molecular test. So there are molecular tests available. Particularly as we know that some of these methods are the most common one is PCR, and PCR can be used for VL, CL, and DCL also. PCR becomes more important and significant when we say that as I said, that some of the species, they can under some immunosuppression or some other conditions, they can visualize non-visualizing species, they can visualize, and vice versa also. Like in as I said, that when the barriers of the Iran bar or Afghanistan bar, the Americans, when they went back to America, they developed visceral leishmaniasis, even though they acquired cutaneous leishmaniasis. So it was Leishmania tropica, but it visualized, and they developed visceral leishmaniasis. On the contrary, in Himachal Pradesh, several species, they have been visceral species, they have been found. Visceral leishmaniasis means Leishmania donovani has been found to cause cutaneous leishmaniasis in Himachal Pradesh. So that kind of things, obviously the serology may not be that good, and that is specific. So in that case, PCR or the molecular test, they become more important. Next, please. Then obviously, because of the high sensitivity and having the specific gene targets, these molecular tests, they have edge over the serology, as already mentioned. And some of the the targets or the primers which are developed for, they include at 8S rRNA gene, then a small subunit rRNA gene, then cysteine protease, mini axon, beta tubulin, GP63, and then ITS, and then microsatellites, and of course the kinetoplast, which is very old one. Next, please. They are all reviewed in the IGID paper, which Dr. Mirza was mentioning. And then studies, they have also reported that they can be used with the high sensitivity and specificity in the bone marrow aspirates, lymph node aspirates, and also in the other aspirates. Then nested PCR can also be used to see the highly specific yields, and they can also be used for the PKDL by aspirating the lesions. And obviously the various combinations of the molecular test, including the FRET and MCA, and then multilocus enzyme electrophoresis, these they can replace the gymodeme analysis we used to do long back. But these days, with the advent of the sequencing, these very time consuming and cumbersome tests, they are not required, and molecular tests, they can give as much information as you want to. Next, please. So this is again very recently one review that is 2025 only I took from there, and then they have compared. So various tests here you can see that on the left side almost all tests you can see that all lines they merge about here, and they are having the sensitivity of almost 99%, whether they are molecular test, good molecular test, or the RK39 or KE16. So I think I would love to have the questions if you have next, please, rather than, because this was a only very fast, rapid fire presentation, because I was told that because two speakers, so I had to compensate their time also, because Dr. Dr. Ashok Rattan wanted me to cover in 15 minutes, and I promised him that I will definitely, even though number of slides is more, but I will cover in 15 minutes. So I have done that. But I would love to have discussion and questions if there is any. And obviously, I would like to, before I end, I would like to thank various funding agencies, including the Department of Biotechnology, ICMR, European Commission. We got good money, NIH, WHO, CSIR, and DST, of course. And then my colleagues from international and national fraternity. And these are some of the students who worked on the leishmaniasis, and they were part of the long career. Thank you very much.
Thank you very much, Dr. Sarman Singh. You have made a significant contribution in making the diagnosis simpler and definitive, and that has led to help in eradicating